September 16th, a Thursday. The session is starting a little bit earlier than usual. And the topic today, precision health, transforming healthcare. We've got a prestigious group gathered and an excellent presenter. The session today will run through to about 5 o'clock. I'll open it up for discussion after the presenter and give the panel a chance to respond initially. If anybody in the audience wishes to pose a question or make a comment, observation, use your chat function. Other than that, if you'll mute your speaker during the presentation by David, without any further ado, unless there's any points that people wish to make right now, it's over to you, David. Introduce yourself and let's hear what you have to say on the topic.
Thanks very much, Perry, and thank you very much as well for inviting me. This is nice to be with a group like this and talking about a subject that is very much near and dear for me these days, in particular. So I've got my presentation titled "Precision Medicine: The Promise and Peril." I'm not trying to be overly dramatic, but I am going to try to, as I sort of go through some of the overall contours of this area, I always make a point, or I always feel it's important to not be cheerleading too much. I think we sometimes have a tendency with, especially new technologies, to almost have sort of a, wow, this is amazing, let's do it all, and sometimes that's great, and sometimes that leads to really exciting innovations and things. But it's always worth recognizing, where some of the potential downsides can come in, and so I'm sort of very excited to kind of talk about that with all of you, and see where things go. So to introduce myself, I am a faculty member at the Cummings School of Medicine, University of Calgary. I'm a senior instructor, so I mainly take on a teaching role there. My background is in bioinformatics and statistical genetics, so I'm the type of researcher who typically never actually looks at or touches a living thing. I'm usually, looking at stuff on my computer screen is the reality of my existence. One of the roles I have these days, which is part of the reason I'm quite excited to be here, is I'm the director of the new program that we've now created at the Cummings School of Medicine, a graduate program in precision health. So this is a full master's program now. We have our first cohort of students actually working their way through it presently. So what I'm going to aim to do is sort of talk through some of the essentials of this area, precision health, precision medicine, and kind of build to where I sort of see big essential things coming in the future in Alberta and Canada and by extension, everywhere else. So a quick note maybe to start off, the terminology here, as we were sort of talking about before, is a little bit dicey and sometimes does get tumultuous. So, lots of terms are out there. There's precision health, precision medicine, personalized medicine was quite popular for a while. Stratified medicine was a term that was there for a little while, I think, until maybe people realized talking about stratified health was not always the best thing to do. And sometimes you see other, related terms coming out. I do think that many of these terms actually do have slightly distinct meanings. In particular, I will try to talk about the relationship between precision health versus precision medicine. I sort of see precision health as being almost a broader perspective, really including all of the elements of the health system, where we're thinking about not just, say, medical interventions, but also, prevention and public health and those sorts of activities, things that we can do. Whereas precision medicine, I sort of think of as being, very much focused on the clinical implications here. What can we do clinically in a sort of more precise and directed way? Perhaps we'll talk about these definitions when the panel joins in too, because I do realize there's some diversity of opinion on these things as well. So to start off, I think it's worth, if we're going to talk about precision medicine, we should talk about sort of what it is attempting to distinguish itself from. So if we think of sort of historical approaches to medicine, again, dramatically oversimplified, but I often think of it as sort of this kind of process. One may start with, say, symptoms, reports of some features or something that an individual is experiencing. maybe collect some additional tests, depending on what symptoms they're reporting. And then essentially, the sort of approach is we try to group patients together with other people who are like them, right? Okay, this person has high blood pressure, complaining of dizziness, 45 years old, male, and you start to fall into kind of a bin, that with like people. And eventually, with the system, we essentially sort of say, okay, you're in this group, and this group, most of the time when we give them this medication or take this approach or this, therapy, there's a benefit. They improve and their health improves. And that's sort of the canonical approach, I think, for most sort of medical decision making. The idea, I think, with precision medicine is to try to essentially take this slightly distinct approach, which is to recognize that, actually this breaks down eventually, right? That approach is never going to fully address every person. There's always going to be some group within any individual bin for whom a particular therapy actually won't be beneficial. And by some estimates, this can be quite high, right? It's sort of 30 to 70% are the ranges I am typically familiar with, where, recommended therapy actually doesn't really help. And so, what precision medicine has the potential to do is actually, allow us to customize our clinical decision-making in a more directed way and in a more sort of individualized way, if we like. So the way that we do this really is driven by certain technological innovations. So I am going to sort of touch on what I think those core technologies are, and just really, really briefly sort of talk about, how they let us kind of address this, personalization, if we think of it, of our approach. All right, I also usually like to start off with something like this, which is to remind everyone that we all have something, and actually we have a lot of somethings. So every person, inherits something. We've got all kinds of things sort of lurking in our genome, in the stuff we inherited from our parents. If we're lucky, these are things that may not manifest, at least not in serious ways, or perhaps at least not until we have lived a good long life and all those sorts of things. But yeah, in some cases, we can have things that can have real impacts. And so, what we're doing with precision medicine, I think, is trying to, in large part, reveal these somethings, if we can, and if possible, try to understand what they're doing, or what we can do at least to, alleviate negative outcomes or make it less likely that something bad is going to happen. Okay, so precision medicine, is very much a sort of technologically driven area. So, if we look at sort of the key technologies, these are what I would, basically describe as the big ones. So, top of the list, I think we have to recognize how much gene sequencing technology has really driven this area. So, when I teach my undergraduate students about sort of sequencing approaches and those analyses that we use, oftentimes, it's important to recognize, we had great innovation in the late 70s. In 1977, Frederick Sanger described the first sort of good DNA sequencing approach. And that was really kind of what we used for the next 30 years or so. It was really the same core technology that dominated how we measure the content of genes. That's how we, sequence the human genome. And so really, that stayed the same with slight improvements, of course, but really the game changed about, say, 15 years ago, when we saw the so-called revolution in sequencing, sometimes referred to as next generation sequencing, that's led to this incredible scale up of our ability to measure contents of genes. I do want to emphasize there are other approaches, what we call high throughput sort of molecular diagnostics. So other tools that are in this repertoire, though perhaps not as singularly emphasized as sequencing. Also important has been the development in computing machinery. So the ability to actually deal with the scale of data that we can now produce. And then finally, the way that we deal with our clinical data, integrate it, digitize it, connect it to all of these other kinds of tools for measuring these qualities that really distinguish each of us. All right, so to orient everyone to the world that has obsessed me for the last couple of decades. So this is a figure from the 1956 paper by Francis Crick. So sort of part of that famed pair of Watson and Crick, who first described the structure of DNA. And arguably, a model that he developed that was as important as that original DNA model that led to their Nobel Prize and gave birth to the field of molecular biology in general, which was this articulation of what was known as the central dogma of molecular biology. Name's quite dramatic. He later regretted that to some degree, but it essentially works like this. If we think of the way that information works in our cells, we have DNA as kind of our repository. So DNA being the stuff we inherit from our parents that is essentially containing the blueprint for what our cells can do, what all the components of our body are able to deploy and use in order to create the kind of living system that comprises us. And then you can kind of think of this as basically the processing of that information. This is really almost the machine that takes the blueprint, which on its own isn't actually useful. DNA doesn't actually do very much on its own, and create something that can do something. So we take our DNA, we convert it into RNA, kind of a temporary sort of waypoint, and then that RNA is used to inform what we create at the level of proteins. And proteins being the thing that really drives functions in the cells. These are the molecules that actually do stuff. So when we talk about the omics approaches, which are intimately kind of connected to this precision medicine world, we're basically doing the following. So we're looking at certain types of omics, genomics, and the related exomics, which are both basically looking at what do we have in your DNA. So exomics is just a subset of genomics focused on the expressed parts of the genome, the parts that actually produce proteins. We also, though, see important other tools such as transcriptomics. So transcriptomics basically looking at the content of RNA. And here you can think of the difference as basically being you're reading the blueprint here, and here what you're doing is actually looking at what are we using that blueprint for. So for instance, in some cells, while we may have a certain gene for a certain enzyme that could break down a toxin, well, if that gene doesn't get used, if it never turns into an RNA copy, well, then it doesn't actually help anything, right? If those cells are exposed to that toxin, you don't have the functional component around to deal with it. And so these kind of approaches are ways you can kind of think of as two different ways of here looking at what we inherited, here looking at what's the cell actually doing. So those are kind of what I'm gonna focus in on here. There are other tools as well, but I sort of find this a good starting point to really kind of compare almost philosophical approaches to ways that these tools can be used. So with genomics and related exomics, this is the kind of the scale we're talking about here. So the human genome, full human genome for a regular person is about 6 billion base pairs of DNA. So you can think of this as quite a lot of information. So I always like to show this image here from the Wellcome Trust in the UK, which is a physically printed out copy of the human reference genome. So these are all volumes. The numbers correspond to different chromosomes. You can go here, you can open it up, and it's page after page of A, T, C, G, and so forth. Utterly useless from a perspective of any kind of actual analytical purpose, but kind of neat to look at just to appreciate the scale, I guess, of the data that we're looking at. So if we want to measure an entire genome, we're generating a lot of information about a person, right? 6 billion possible points of data. Every individual person has millions of points that vary, that differ from others, which means that, if we speak statistically, it literally is true that every person, unless you're an identical twin, although even identical twins get some differences, are going to be unique at the genomic level. You're going to have a totally unique combination, one that has never appeared before in the history of humanity, and one that will never appear again unless you get cloned, I guess. So this is important to appreciate because many tests, when we think about precision medicine, are actually not necessarily doing what we think they're doing. When we say we're measuring someone's genome, we're often actually using tests that really just specifically test for what we call known variants. So places where we know that the genome varies and that it may have some consequence. So 23andMe is a good example here. I'll mention 23andMe more a bit later. But yeah, it's basically just a presence absence. Do you have this interesting variant or not? And that's quite different than if we use, say, an Illumina sequencer, where we can measure, the majority of a genome's content for a few $1,000s. In this case, we're only going to detect things we're looking for. And in this case, we could find new things, right? We can find things that may not be known and may not actually be that well understood. Okay, so who should we use this for? Well, this is an interesting area, right? We need to decide, we're talking about prices, we're talking about cost of these things. And on the one hand, some folks I know will argue, well, we should just sequence everybody, right? Why not? You can work out the economics of it, what the cost and what the potential benefit might be. But right now we don't do that, and certainly not within our system. So instead, we sort of have this prioritization list, looking at people who have very difficult cases, maybe undiagnosed, very complex sort of disease presentations where, again, we may not understand everything, or potentially where there's some relevant family history, right? These are the sort of general indicators that we might use to target the use of these kinds of genomic-based technologies. There's also this argument, which is that, well, if you measure your genome, it's different than any other type of test that we do in medicine, right? Because a genome is sticking with you. I mean, there are ways it can vary a little bit, but it's going to stay with a person for the rest of their lives. And so, maybe it makes sense that we prioritize children here because, hey, the benefit then extends out for years and years and years longer, right? If we're talking about sort of the economics in the system. In particular, people will emphasize that if we do this for children, we can identify potential drug interactions. By some estimates, we could reduce the number of adverse drug reactions by potentially half, just using known genetic markers that could indicate that someone's going to have a bad reaction to a certain drug. We could also identify perhaps certain vulnerabilities that could allow people to take lifestyle changes on and avoid really, really awful negative outcomes. I'm already going to run long, and I apologize, and then you can cut me off at some point here, as I said.
You're doing fine. Go ahead.
So the transcriptomic side, I like to emphasize here because I do want to make it clear, sometimes there is almost an equation between precision medicine and genomics specifically, but that really only gets us a little bit of the benefit here. And so, for instance, if we look at transcriptomics, where we measure the RNA that's present as opposed to the DNA, what we're really doing is we're figuring out what the cell is doing with its genetic information. So the majority of the parts of the genome don't actually get expressed in every cell. I mean, this is why our cells are different. Our neurons function differently than our skin cells and than our liver cells. They have the same genome, but they're just using it differently, right? And so this is where the benefit of actually measuring what a cell is doing can come in, because here we can actually reveal important mechanisms, things that are causing a disease to occur. And if we understand the mechanism behind a disease, that can reveal possible therapies for it, possible ways that we can disrupt whatever the etiology of the disease is. So for example, where we're really seeing transcriptomics being deployed with good effectiveness is in a lot of cancer cases. So recent studies, using transcriptomics for relapsed cancers found that it was about over half, I think, of the cases when they did the transcriptomic assay revealed some intervention that they wouldn't have used otherwise. It showed this particular mechanism underlying the tumor, and oh, hey, if we throw this drug at it, that targets that mechanism. And so there's this potential to, again, really customize the kind of therapeutic approach that we can use in really exciting ways. Okay, the last one I'll emphasize here is the so-called metagenomic approach. So I like this one because it's sort of simple, even as it's incredibly complex. So metagenomics, essentially what we're doing is we're just sequencing everything that's around. So rather than just focusing on your genome, your human genome, this approach is really about what's present in a particular environment. Could be inside your gut. The gut is a really important target, right? We have tons of bacteria and viruses that live in our guts. If we extract sample from your gut, we can just say, hey, let's just take all the DNA, sequence all of it, and figure out what's there. And if we know what's there, maybe we can diagnose someone with a certain type of infection that otherwise might not have been detectable. The other really exciting thing about sort of the metagenomic approach, where we're seeing it used, is to actually monitor population level health. So for instance, the recent ways of detecting the presence of COVID, identifying COVID outbreaks by neighborhood by looking at what's in the sewage, right? We can extract samples out of the sewage, sequence everything that's there, or isolate viral pieces. There's tricks we can use. And if we see the SARS-CoV-2 virus popping up in the sewage, well, there's only one way it's going to get there, right? It's if the people living there are infected. And this is actually proving to be, a really valuable way of monitoring sort of population health looking for things that could be sort of foodborne or present in all sorts of different places. Okay, so those are sort of the focus on the tools. I mentioned the importance of computational infrastructure. I'll kind of skip over that because I already know I'm running long. But I do want to mention, the AI question here, because this one often comes up, and I think it is important. It's a really important one for us to talk about if we're thinking about sort of the future of this field. So the benefit of AI, machine learning tools kind of being the most famous subset of this group, are that we have this ability to really leverage all this computational capacity in a way that allows us to identify patterns that would just be impossible for a human being to identify. And this is really important when we're talking about generating 6 billion pieces of information about every single person, right? Or even more if we then combine it with transcriptomic data or clinical data or all the other kinds of data we can collect. And so this is where I think the future is really going to be developing in the next 5 or 10 years, is how do we actually leverage the scale of data that we're producing to identify complex patterns that might allow us to potentially pursue new therapies, but also to predict outcomes. I mean, one of the interesting AI tools that I've seen published in recent years was a study that looked at essentially just prediction of imminent death. So, huge scale of patients in the study, taking all their clinical measures, all their blood metrics, and what's the pattern? What are the underlying patterns that predict someone who's going to die in the next month? And if we know something like that, I mean, there's all kinds of things we can do, right? Maybe to have much more careful monitoring of someone. Maybe hey, there's something up, we should revisit their medication or their therapy regime or whatever. And so, yeah, there's a lot of sort of exciting potential in this sphere. I'm close to done. I'll mention 23andMe because I think this is sort of the elephant in the room when we're talking about precision medicine, because they are, at this point, really the dominant player. So 23andMe, a big provider of genomic testing. It uses what's called a microarray test, which means that it is limited only to known variants. It's also a direct consumer test. So this means you don't need a clinician involved in order to access it, right? Many people actually just, you get this as a gift, right? And you get tested, learn about your ancestry and that sort of thing. It does include a lot of health reports. And so, these potentially have consequences. The way we interpret them have consequences. And this is where this microarray piece becomes really important, because the microarray, as I said, is only going to look for the variants that whoever designs it decides are important. And that means that for any individual health report, it's only going to be focused on a certain subset of variants. So just to give an example here with 23andMe in particular, it will report on someone's BRCA1, BRCA2 status. So BRCA1 and 2 being the breast cancer associated genes, for which there are many known variants that if you possess them, may be a near guarantee that a woman will develop breast cancer by her 50s. Now, there are thousands of known variants in those genes that impact your risk for breast cancer. And 23andMe tests for a couple dozen. So those couple of dozen are ones that are relatively high proportion or highly common among people of Caucasian and Ashkenazi Jewish ancestry, but a relatively lower proportion among other ethnicities, which means that the relevance of that health report will actually vary depending on your sort of ethnic background. And so decisions around that sort of thing, what kind of tests you do, how you focus this, how you decide your reports, actually have real consequences for who is going to benefit, who can actually receive the benefits of this. I always feel the need whenever I mention 23andMe to point out that it is also a privately owned database. So it's a two-sided business model. You pay a certain fee to get tested, but you also have to sign or agree to their terms, which include that they can anonymize your data and they can sell access to that to a pharmaceutical company, which they do. And they make a lot of money off of that side of the business as well. So who profits from someone's genomic information is its own pretty important kind of ethical question that I think we need to visit. All right, last thing I'm going to say, as I mentioned, I'm directing this new educational program, so I have to show a little bit about it. So when we developed our precision health program, we had a big debate about what were the right sort of components to focus on and what was the right material that we really needed to have. And we kind of came to a relatively unique conclusion, I think, which is, if we view precision health under this broad lens, where it's really about leveraging this sort of big data, big computational era to support health and wellness among the population, among everyone who lives, in a population, then actually it's about a lot more than just the technology. So if we think of precision medicine, as I said, was very focused on the deployment of certain technologies in a clinical space. Well, that's obviously important. So, that's we've got this big circle here focused on those molecular and computational tools as they're applied to health. But it's not enough to just have people knowing, okay, yeah, I know if I get a genomic test, I can do this. And I know if I get a transcriptomic test, I can do this. If we're going to bring these things online, we need to be thinking about the impact on the system as a whole, right? We can't always be just, as individuals paying for it out of pocket, or maybe we can, but that's going to be a very different system than one that we have right now. And so we kind of came up with a few different areas that we thought were also critical. So one was this focus on quality and safety and leadership. So, what are the approaches we need to have in a health system if we're going to actually make decisions about when it is appropriate to use certain precision medicine tools, right? When is it appropriate to acquire a sequencer or to hire a data analyst or a clinical bioinformatician or someone who can support the use of these tools in a clinical space? We also identified this key need for education. So, clinical personnel, clinical professionals have not historically gotten a huge amount of training in the use of precision medicine tools, right? This isn't a sort of conventional part of the medical education programs. And so there's going to be a really important role for health educators, people who, educate nursing staff, doctors through CME, other aligned professionals in how to appropriately deploy these kinds of tools in those spaces. And then finally, this circle on innovation and entrepreneurship, because these are new technologies. And whenever you have the sort of development of a new space like this, you're going to see certain people who really drive this innovation forward, invest in it, build businesses in many cases, or in some cases, it's innovation from within a larger health system, right? You can also look at examples like the National Health Service in England, where they really innovated in this space, right? They built out their infrastructure in terms of sequencing. They built out their capacity in terms of analysis. They built out the training of their personnel. And so we kind of identified these four different components as being really essential to, if we're going to realize precision health at the scale of the system as a whole. So for instance, in that precision health program I mentioned, we've articulated 4 different specializations that are all kind of linked under the aegis of this larger subject, and where we're really hoping to sort of, foster the kind of cross-pollination between those who, for instance, are really interested in understanding how genomics tools work, how we can build new analytical tools, how we can build new AI tools to actually use them clinically, along with, people who want to think about how we innovate in the system, right? Do we build a new company? What's the business model? How do we justify a certain expense when we're thinking about future leaders in the field and future educators in the field as well? So that's where I'll tie things up. And thank you thanks for bearing with me. And as I know, I always tend to run long, even though I try my best sometimes not to. And yeah, to sum it all up, I think there's a lot of promise here, but we also need to be aware of where the potential perils are. So, this equity challenge in particular, we know that a lot of the data we're generating in precision medicine is driven by certain, subsets of humanity. So we're talking about largely people of European descent. And so if we don't sort of carefully consider this, look at how we're prioritizing sort of future investments in this sphere, what we're going to see is, the existing inequities, if anything, just exacerbated as we have precision medicine come online. If we don't want those benefits to be so uniquely divided, then these are important things for us to consider. And that's where I'll stop. And I really look forward to this chat with all the panelists and with everyone else. Thank you.
David, this was superb. Thank you very much for an excellent overview. It was highly educational, informative. Your pace was good. And I feel I've learned a lot from what, and I'm sure others have as well. But I do have a question for you that may set up the opportunity for those in the panel to respond as well. There's a phrase that if a tree falls in the forest, but nobody hears it, did the tree really fall in the forest? And you're a researcher at a university, and the key question, of course, to the public is precision health really yet clinical? Is it in the market? I did a session a few years ago on cell therapies from the lab to the bedside, and those at the bedside were desperate to get whatever was available, but Canada Health stood up and said, no, we're not ready to authorize and approve. Is what you are finding in others in genomics or in the digitization of healthcare really finding its way to the bedside, to the clinic, to the patient, to the person?
Yeah, so that's an excellent question. I'm very interested in some of the other panelists' opinions on this too. So I think my answer right now is that it's yes, with a very substantial asterisk. And that asterisk is that I think the process is incredibly haphazard and fairly ad hoc, actually, in terms of how it makes its way when it does, as you say, all the way to the bedside in terms of actually benefiting real patients in real time. So, what I mean by that is at this point, you mentioned Health Canada kind of standing in the way of certain therapies. When it comes to a lot of the kinds of testing that we associate with precision medicine, Health Canada has at this point actually been very, very sort of standoffish and really hasn't put regulations out at all. I mean, at this point, by last count that I saw reported, there are several hundred different companies that are accessible to Canadians right now that you can just directly order a test of your genome or other, related component. And so that means it's very ad hoc, right? It means that people are making these decisions kind of on their own, maybe sometimes in association with clinicians. Certainly I hear those stories as well. The story I often tell is this one. So myself, my background, I'm not a clinician. I'm, as I said, a researcher, bioinformatician. And a number of years ago, I had a friend who had a child that there was some worry there may have been, some issue. And so they recommended a 23andMe test, which they did, and then didn't see what they were looking for, and then said, okay, I guess that's that, we'll move on. And of course, the reality is that when you do a test like that, there's tons of information there. And I don't really know a person who has the ability not to want to look more deeply once you have that sitting there, right? But doing that, and that's where I think the real gap is having, the capacity in our system to have actually, trained professionals associated with the health system, with the clinical system, who can actually make use of this data. And as long as it remains sort of in this predominantly direct-to-consumer model, what we're going to see, I heard one MD use this phrase, which I thought was brilliant. We're essentially seeing a field that's driven by the worried wealthy. And those are the people getting the tests, and those are the data sets.
The worried wealthy.
Yeah, exactly. And so
I'm going to call on Lawrence then. In reading Lawrence's CV, he talks about patient outcomes, and he's clearly has moved from the genome to the patient. Lawrence, you want to pick up on the discussion about whether or not this is just research or whether or not it's really finding its way to make a difference in outcomes to health?
Yeah, sure. Well, thanks, David. Great setup. And my answer will be, it depends on which area of healthcare or medicine you're talking about.
Good.
Precision medicine is standard of care in oncology today. The decisions around medicines are being based on genetic profiles of tumors, and that is increasingly evolving. And I'm sure Chris will speak to it, certainly driving costs in a certain direction. So certainly in oncology, I would say the potential, so our ability, the way I think of precision health is, when you think about somebody on steroids, precision health is health on technology. And, really, it's not that the practice of healthcare or medicine has changed fundamentally. There's always been an effort to try to choose therapies, management choices based on individual characteristics or or preferences. What's changed today is the technological advances, which are exponentially increasing. The number of ways we can dissect a human being is so much greater that it's fundamentally going to change the way we think about providing care and making decisions. So that sea change, I would say the healthcare industry knows is coming. This is why it's an interesting topic, because it is unavoidable. It's coming. It's here in oncology. I would say it's here in rare disease to a degree, but it should be more. I think we've got some improvement to do there for sure in the context of children with rare disease. I'm on service this week, and this is a typical scenario. A child is showing some regression in skills, motor skills, speech skills, social skills. This requires an investigation. If we applied a precision medicine approach, in my opinion, it would be far less expensive and far more efficient if we did. The approach we use today is we cast a wide net and we spend a lot of money up front, and then hope we get some answers at the end of that. So yes, it's here in some areas, it's coming in other areas, and this is why we just need to keep talking about this and doing research, because I think where it's going to impact health, where we think it's going to impact health and where it's going to impact health, I think we don't know where it's going to impact health next. Lots of ideas. Most of them are not going to come to fruition. Some of them will.
It's amazing when you explain, David, and I'm going to pick up on your comments, Lawrence, when you talk about the relationship between DNA and RNA. Does the health system function like that? I mean, I see we got lots of DNA with lots of information and knowledge, but the capacity to actually move it to the patient, which is, I think, what the RNA did, we seem to be lacking. And I'll blame it on the wine. It seems we've got a great top system from the top, a system really chasing knowledge, but a system that needs lubrication, needs somehow a vehicle to move things more quickly from the knowledge level to the application level. And I'm going to ask Christopher, this seems to be a field of some interest to you. Do you want to pick up and add anything to that point or make one of your own? And unmute, yeah.
Yeah, thanks, Barry. Yeah, I've been thinking about this stuff from the systems perspective, probably a decade or so. And I think there's a few observations I'd like to make. David really set the scene quite brilliantly, so thank you for that, David. And Lawrence, as always, leaves me with a problem or two to address. I think it's what he's on earth for, I sometimes think. But yeah, it's important to realize that DNA and RNA are not deterministic. Okay, so it's not, if you see X, you aren't guaranteed to get Y. Even with the BRCA1 and 2, it's incredibly likely, but it's not a guarantee. So we get data, we get some information, but we don't get knowledge. And what's at the core of trying to think about how we deal with this revolution in information is how much more certain it makes us about what is the correct clinical pathway, clinical strategy. As long as we say, in a lot of ways, clinical practice hasn't changed. They still take a history, they still take a test. Now the test now delivers information, a lot more data and information at a lot more granular level, but it's still information that requires clinical interpretation to convert into a diagnosis, that content knowledge. And there's a great phrase about as the price of the sequencing goes down, the $1,000 sequence, it's the $1,000 sequence and the $100,000 interpretation. So the fact that generating the data is cheap doesn't mean that turning it into health for the patient is cheap. It's still incredibly expensive because you need those experts, those content experts, people like Lawrence, who can bring the information from the test to bear on all of the other information, the family history, the symptoms on examination, to arrive at a diagnosis. And that means that at a system level, we can't just say, yeah, sequence everyone the day they're born, and then we'll know what their trajectory, their health trajectory is going to be, and therefore what healthcare we need to provide to them, what preventive interventions. That's not what it does. First of all, it's incredibly expensive to convert the test information into an interpretation of what they're likely to see in their lifetime. Actually, most of their lifetime health is not going to be a function of what's read out from that sequence. It's going to be a function of environmental factors, behaviors, choices. And we know, much as we would all love to think that when we tell someone they've got an elevated risk because of their genetics, they'll change their behavior, we know they don't. Information does not change behavior. And what this precision medicine, precision health does, it generates a huge amount of additional information. What we have to learn and develop is how to change the behaviors. And some of that will be about behaviors that the individual adopts with support. Some of it will be about services that we provide to the individuals. And some of it will just be stuff that we don't really know what it means yet. There's lots of our DNA that we can't actually currently attribute to its impact on health in a way that is truly actionable. And that's one of the big challenges. In oncology, we've come a long way. It's probably the place where we have the most application. But perversely almost, oncology is the place where we got so far that we know it's not individualistic care. It's, our DNA doesn't drive us to being unique. We've now got in oncology, we're seeing what they call tissue agnostic tests. So it doesn't matter whether it's a breast cancer, an ovarian cancer, a liver cancer. If it has the same molecular structure, then you treat it with the same drug. Whereas we used to say, this is a drug for lung cancer, this is a drug for breast cancer. So all we've done, as it turns out, now we've gone through full circle, so to speak, is we found out that we're grouped in different ways. It's not that we're individual and unique, it's just we're in a different group. And this detailed understanding of the molecular drivers of ill health in cancer care is actually turning out to be a new way of grouping us into groups. It's not personalized, but it is precision. And that's one of the ways where I think it's useful to, as David was indicating, differentiate between precision medicine and personalized medicine. Good healthcare has always been personalized. This molecular genetic understanding is allowing us to get precise in some places, but not precise down to the individual. And frankly, we'll never get to that level.
So I'm going to pick up on the digitization in clinical data. We've talked a fair amount about the genome, DNA, and what all we can learn at that level, which is sort of inside the person. There are wearables emerging today which allow data to be generated that the client shares with the clinician. And that's the world that Randy Duguay is in, where Randy may never see a patient, but he's got an enormous troves of data that is generated from the person and shareable to the clinician. Randy, you want to share with us why you're in what you're in and what you're learning?
Well, I'm pretty sure most people would have to agree with me that they would never want to be a patient of mine, because it's not my experience. And in fact, I was talking to a good friend of mine, Dr. Jonathan Burns in BC today, teeing him up for a session just to make exactly this point, to speak to the topics that I don't know much about. But I do know a lot, and I do have a lot of experience in the world of innovating in digital health. And also, my time in serving various boards or community activities within the health system. And so I do love this discussion and the point on behaviors. The work that we're doing in the capture, in our case, ECG, PPG, activity, sleep monitoring, these are just starting points in the current state of, frankly, really, really inexpensive sensor solutions. And so the whole idea of collecting data and how that can be done in community settings and at home and on the body on a more continual basis is, I think, just a really huge area to contribute to supporting people as they go through their lives in the clinical journey. And the point for us has more to do with behavior than per se, the deeper topics of precision medicine, which you have lots of qualified experts here to talk to. So it's really the intermingling. I think we're heading into a world where information and the gathering of information is now moving quite quickly outside and beyond. Not so much. Not that it will not include clinical settings, but the world as a clinical source of collecting information is just at the beginning, and so how all this data comes together. So in his wearable technology, how we can impact on behavioral change, and I'll talk a bit about that in my notes, is I think just a very green space still to develop.
Well, I'm sitting here jotting notes and thinking of the days when I was getting my degree, and nature versus nurture was constantly being thrown on the table, whether or not psychologists should be working with doctors or whether or not we should have something that works between the two. I think we've arrived at that point. Personalization of healthcare, as Christopher elaborated on, is as much about lifestyle and experience as it may be about the DNA. And I think Randy brings that to the table. Most physicians, I presume, tend to lean one way or another, and they tend to lean more to the body. Or am I seeing changes in the education of doctors? I know that in Hamilton some years ago at McMaster, they designed a revised criteria for assessing which students should be admitted to medicine. And we're looking at relational skills as the capacity to actually help affect behavioral change, which is quite unique and original, but a recognition that health is more than just the DNA and more than just the body. Anyone want to pick up on that further and elaborate? Although the point I think has been made. Lawrence, you're stirring. I think you're going to unmute it. Maybe yes, you are.
Yeah. I want to pick up on the point of the need to think differently about education. Yes. Of professionals. Absolutely. But first, to agree, I think you did make the point that understanding behavior, understanding people, where they're coming from, is a human skill that I was happy to hear Christopher didn't think I was going to be replaced tomorrow as a clinician. But I think that human element potentially will be amplified. The need for that ability to communicate at the human level will be amplified by precision medicine. So that, because otherwise, if you're nothing more than what a computer could do, you haven't added anything. So I think if anything, I'd like to believe that the precision medicine may amplify the need for that humanity in the health professions.
But that's where I see the phrase personalization becoming so key in all of this, because it seems to imply that we've talked a lot about client or patient focused healthcare, but personalization says that the individual now has an education. They have access through the internet to think they have data. Maybe they do, maybe they don't, but they want to know a little bit more about the relationship with the doctor, and the doctor probably should say, this is good news because you're going to be my partner in this exercise. Yeah. It's just not me telling you to take your medicine and go home. We got to change your behavior as well. Well, this is a whole, well, the family doctor used to do this because he knew the family and knew the person in context, but the specialist who only looked at data in the lab was losing something. And now sounds like we're coming back to it.
Yeah, I agree.
There's a book, I think it was David and his son Ravinovich, called The Future of the Professions. And it wasn't just talking about healthcare, but it was talking about all of the professions that were knowledge-based. And saying that the client, which is one step above a slave in Roman times, is becoming a consumer. They think they have knowledge, so they shop. If they're not getting what they think they need, they'll shop around. And they just demonstrated in England and got them to abandon the passports because they think they know more than the professionals and the physicians and the government. This is change. And it isn't just the patient that's changing. It sounds like the professional is changing as well. So is curriculum changing?
It needs to. Maybe that's a good question for David. Actually, that's.
You want to pick up on that, David?
Yeah.
Well, I was going to say we're trying. Yeah, I mean, actually, maybe this is the way to say it. So when I first kind of turned into the education side of this, it really came from, connections with a number of people who were trying to innovate in this space, build companies that could do these kinds of testing and provide it. And them sort of realizing, the main challenge they were facing wasn't technological. It wasn't in terms of sort of the supply pipeline or the identifying clients. It was really just making sure that the clinicians with whom they were working were capable of sort of knowledgeably deploying what they had to offer, right? And so, when I came out to Calgary, we talked a lot about this. I started out doing some workshops through CME, the Continuing Medical Education branch. And of course, I think most people agree, yeah, it would be great if we could have, this content embedded within the main, UME, the main MD degree. The challenge, of course, is if we add something, it's not like there's a whole lot of extra space in the MD training program, right? Like it's, there's a real tough negotiation there of, well, if you're going to add in a whole lot of emphasis on omics, let's say, what are you cutting, right? What are you taking out? And that's a very difficult and sort of drawn out conversation, I think. And so at least in our case, this very recent history, we kind of decided, well, maybe what we can do just to do something faster is we just create something new. And so that's, why we created this precision health program, because we were trying to focus on something, okay, we can get something going, try to make it, this fulsome embrace of what precision health means at a systems level. And then hopefully over time, we'll see as we develop these educational systems and programs, a way to sort of better integrate it into sort of the core training programs that there are for all MDs. But I think, that's a main challenge here, right? I mean, we can generate the data, we have the technology, we can store it, we know how to construct the right kinds of databases. I mean, there's always challenges around that, but they're not the major one. The major one is we need the right kind of people who can use it. And I agree. I don't think the human disappears in this. I am not the kind of technologist who says, yeah, we're going to have AI doctors, man. Like we don't need people, in the lab coats anymore. We can just plug your data in and tell you what's going to happen. And I don't think that's realistic. I really don't. I think the key is we need to make sure that sort of the clinical professions are trained so that they can deploy this stuff, appropriately, responsibly, and effectively.
But the rate of change is an issue in itself. I mean, it's all well and good for you to graduate someone today, but the word exponential was cited early on. Continuous learning seems to be a monthly affair or annual. But if the profession on board, or is the profession just desperate for status quo? Are the doctors willing to learn? You talk about change management. Are doctors, I've heard, they get their certificate. Thank you very much. Doesn't sound to me like getting a certificate is the end of the road by any means. And continuous learning must be if it's thou shalt do no harm, or that's going to do the very best we can, staying up to date on what it is now becoming clinical versus just laboratory must be quite a challenge in itself. Randy, what are your views on that? I mean, you're talking about bringing information now about it's live data that's available if the clinician wants it. Are you finding a receptiveness?
Well, I think that the discussion around systems thinking and how the world of health services delivery is evolving is very important. Going back years for me, one of the terms I heard, which I thought was incredibly powerful, is this idea that the home is the future hospital, and we really need to digest some of that thinking a bit. Not to suggest that is the end all and be all kind of idea as a concept or a future point, but it really kind of creates this idea of where health information is collected, received, addressed, and we all will have personal experiences, and I can tell you that, my recent experiences with the health system, which is a very defined thing. It's largely about episodic and acute care services, support and delivery. and, until we get to the end of life, really, which changes into something else. But, when we think about how we've really stratified that system, it's become very facilities oriented. And as we did that, we also created these places where we are objects that arrive in these places. And we're really seeing, I think, an opportunity, whereas you go back a century or more ago, the clinicians would travel and they would go and visit in communities. I mean, these are, these romantic ideas of how health might be served, but they're very personal. And, I can tell you that some of my recent experiences, I actually had a specialist phone me after I had a bit of an occurrence, and they phoned me, and I was like, my gosh, there was a system out there where people were doing things where I actually got to talk to a specialist, for heaven's sakes, who phoned me at my house. Now, I love to kind of contemplate this idea of what I call the Uber metaphor. And, Uber would not exist unless there was a whole stratification of really amazing technologies. Uber would not exist if satellites weren't launched and GPS applications weren't created. And so I'd like to think about the digital health future a bit like that metaphor. And if we look at the metaphor, there's only two actors in it. But the thing about digital health is that the driver in the scenario of digital health is frankly a far more sophisticated individual, very diverse. And the assessment of where am I as I work on my health journey and arriving somewhere is also a little complicated. But we are now creating that infrastructure to make that possible. And I think that the health system, I think doctors, and talking with doctors and talking about not just doctors, some of my friends use the colloquial term of doctor to refer, frankly, not just to the doctor, but the community of people and all the stratified support that doctors have. And I'm cool with that. If we have a doctor and they have like 5 or 6 very unique and specialized people supporting me, I'm all in, right? So I think that we're really starting to see that doctors and the various health professionals that go along with doctors are, I find, really quite open to these ideas, because it's a great future for them too, to think that they can serve their patients not by waiting for them to show up somewhere and addressing all these inefficiencies in our health system, but actually can use technologies in ways that has never been possible before. So yes, I think these are really great opportunities where intelligent systems design is going to play a part.
So the word system is continuously used throughout this discussion, which is delightful to hear, because if you're making soup, changing one ingredient in that system does not make the soup any different. We've talked about behavioral change. We talked about genomics. Is there an innovation ecosystem in health? And I'll say specifically Alberta. I mean, I drive to the University of Alberta and I see absolutely massive buildings and commitment at the top end of the system. But is that a system? It really looks top heavy. And the patient, does the patient feel they're part of the system, or they're sort of on the side? If this personalization is real, we have a revolution in our midst, because the party that's been ignored in the pursuit of knowledge is now saying enough is enough. And they've got money in their pockets to go buy things. And that, I was director of privatization and funding reform of the province, and I told the province when I was finished, you don't need an ideology of privatization. The patient's going to take you there. They will pull the health system to their future. Am I dreaming something, or are we actually seeing increased expectations at the patient level making a difference in the way the system operates? Christopher, you're watching economics, but you're probably watching more than that. I picked a little bit on the ecosystem. I picked a little bit on the person as a driver, the top-down mindset. You want to add anything here?
Yeah, I think it's really interesting. There is, first things first, the proportion of people who can be true personal consumers of healthcare is minute. It's 0.00001% of the population. Bill Gates can be a personal consumer. Elon Musk can be a personal computer. But for most of us, the drug costs for one significant health event will wipe out our domestic economy, our household economy. So healthcare is fundamentally a social endeavor. Now, we may pool our funds through private insurance, or we may pool them through social insurance or through tax, but it is a social endeavor because we cannot personally, as individuals, afford to pay out of pocket for our healthcare. Okay, so that means that the pure consumer model, just because I as an individual can get the information through the internet, can have all of my personal data, that does not mean that I can demand all of the healthcare that I want. We are going to have to, our demands are in tension with other people's demands, and the market, will not solve this problem. The market does not solve the problem of in healthcare. There's a classic paper from 1963, Kenneth Arrow, Nobel laureate, explaining why healthcare has all of the characteristics as a commodity that mean a free market will not deliver efficient outcomes. It will deliver exactly what we see in the US. I often say it was the US government that paid Arrow to do the research, which led to the paper. And I often say the US government and then spent, literally hundreds of trillions of dollars doing the biggest field test of a hypothesis ever. And they proved Arrow right. Arrow predicted exactly what you've got in the US. So there is a necessary individual versus social tension in the funding of healthcare. And that creates a constraint on the degree of the empowerment of the IT technologies, the individual patient data technologies can enable or give us the potential of. That creates a very hard constraint, because we have to think and understand how are we going to balance meeting the more informed and specific demands of an individual patient who turns up at Lawrence's office with the data and clarity about what they want, and the fact that we can't afford to pay for everything. The dollars that Lawrence spends on the patient in front of him is healthcare that can't be provided to somebody else. So there is this real tension about absolute individualization of healthcare and sustainable healthcare for all of us. And where we land on that is a value proposition. And there isn't a right or a wrong answer, but we should know that there will be a need for a societal choice or a political choice about where we land on that, whether we privilege the individualism or we absolutely privilege maximizing equal access to healthcare for all. But either way we go, we're going to make trade-offs of other things that we value. And I think that's going to be the biggest barrier for the realization of the opportunity of precision health and personalized healthcare, is figuring out how we manage those trade-offs. And that is absolutely a system level consideration.
Well, there's clearly a yin yang here, almost like nature nurtured. I mean, whether or not there's a lot of nibbling going on that wasn't going on before, where the patient is now playing a stronger role in believing and having expectations higher than they did in the past, which, you all acknowledged. Technology is playing a critical role in actually following that path and saying we can do a better job in individualizing the services. Who pays for it? That may be another matter. But as expectations rise, the Elon Musk, the retired population that's got wealth in their pockets that didn't smoke, that now has money to spend, is going to shop.
They haven't got that wealth.
They're going to shop for cell therapy. They'll go to Mexico. Anyway, I don't want to beat that too far. I think they're nibbling. There's obviously tension, and it's unfortunate politicians have to resolve it. David, you've nodded your head a couple of times here. Do you want to elaborate? You said you've had some experience with the U.S. system. Do you want to elaborate at all?
Well, I mean, the inefficiency of the U.S. system was profound and incredible to behold. Actually, I would say, while living there, and I should say my wife works in frontline healthcare too, so I had sort of that perspective as well. Part of what I was nodding to there, though, as well, that perhaps is worth putting out for discussion as well. I think the decisions we make around the economics of this are going to have big impacts on where the benefits are going to end up. I mean, that's the other part here, right? That's sort of the worried wealthy comment a little bit. You know, I know, so I had some interactions with some folks at the P4 clinic that's in Seattle, which, you know, offers sort of this full service, you know, come in, we'll do every battery of omics type test you can get. And they, you know, they cater to the Microsoft executives and you know, the Amazon executives and so forth. And yeah, I mean, you know, so if you're gearing your whole model towards those sorts of folks, those sorts of people don't tend to skew with the same genomic background as the general population, right? And so this is where you're going to continue to see, again, this sort of reinforcement of the inequities of the system that already exist potentially emerge. And the other thing I nodded to when you were talking about sort of these decision points and the issue of the politicians here, I once had a meeting with a health minister whose name I won't say, not the current health minister, in which we talked about, you know, the oncoming disruption in the system and bringing these sorts of tools online. And he commented that it was scary. From his perspective, it was terrifying, right? Because if you're managing the health system in the province, you know, okay, we can talk all about these benefits, right? And the potential better outcomes and you know, the lives saved, but it's also going to be money. And right now, if you're talking about, you know, trying to keep the hospitals operating and you're talking about a system that's already stretched, the idea of the sort of upfront investment that this probably requires from within the system, it's kind of terrifying from a politician's standpoint, right? Especially if you're thinking, I'm going to invest now and the benefits are going to come, you know, 5-10 years in the future. We don't always have too many politicians with the perspective needed to kind of take that initiative on. So those are the things I was nodding about and thinking about.
This is where cocktail conversation enters into the fray. We're now talking about everlasting life or extension of life. We're talking about what we know in the DNA and what we're beginning to learn about the biochemistry and lifestyle as well. We may have the capacity to extend life. Well, we also know the most expensive stages of life are in those latter years. If we start extending life, are we going to be increasing the costs exponentially, or will we be extending life because you're all going to look like you're 25 and your body will be that of a 25-year-old? I mean, these are conversations we have over wine in the bar, but they're no longer fanciful.
Jump in, Greg. You've been waving your hand.
Go ahead, Greg.
Oh, I was just going to start to rant. Politician, if you're a politician in the People's Republic of China, you might not be flinching as badly on that investment in technology that you speak of.
Why?
Because they've got billions of dollars to invest in anything that will advance their country's interests in the world.
Well, they don't have as much as the U.S. has. I mean, they're getting headway, but your point being that they are more likely or less likely to invest in healthcare.
No, I'm just saying that they've got billions to invest and they want to win the game. So, but they don't have the political process that we have to encumber them, and they have the power, and they're not democratic about it in exercising it. I was going to take it on a bit of a different tack, building on your comment on immortality. I'm going back to a presentation from David Bushnell, who was the chief researcher at NASA about 20 years ago. And he said mortality was possible at a time when no one had heard about 3D printing. So he's saying mortality is within the realm of mankind. I'll quote another Albertan, Axel Meisen, who said, our future is in the hands of the social scientists, not the physical scientists, because of the human problem of moving technology forward. I'll finish briefly with a question. Perry, you've been around new technology, and I go back to when I was at Suncor. Rick George said to me, what does the internet mean to the upstream energy sector? And in the late 1990s. And I met with over 500 companies to give them an answer. This is an evolution in technology. It's no more than that. Yet the work involved in bringing technology into business as usual has been a lifelong challenge as long as we've been inventing technology. And it's really as much as, if it weren't for the scientists, we wouldn't have the opportunity. So thank goodness for scientists, engineers, and others to make this stuff real. It's the people side. How do you move this forward in our complex society? So my passion for the next 50 years will be creating 100% inclusive collaboratives to move that kind of complexity forward. Because you need everyone at the table. You need to share a common perspective. And there's an idea that I came up with about 5 years ago around organic collaboration. You can't manage this kind of complexity with the strategy. You have to manage things organically the way nature does. So there's ways of doing that. So Perry, what would you advise to someone embracing a new technology? Because you've been around about 35.
Well, I think you walked right into it. And I think it's been alluded to over and over again today, that technology is like the tree falling in the forest, nobody can hear it. It's change management. I mean, change management and technology go hand in hand if you want that technology to become expressed. You need RNA in the system. DNA is inadequate. Something has to move it. Something has to recognize that it is needed. And it's also not knowledge. Knowledge doesn't sell itself. Typically, pain is what drives change. The most sensitive part of the anatomy is the pocketbook. And change does not come about in a political system or an economy if you don't have the money to spend on it. And if you don't have a need. I can remember the MLA up in Fort McMurray saying one time, he was a Harvard graduate, he said, God help me right now, I'm 80 years old, I think I forgot the train of thought. No, he made the point that as a politician, you don't want shocks. Well, technology has the potential to bring shocks that David is talking about, that we're all acknowledging what's happening in that one field. And you know, what I've been doing for 15 years with these webinars and with the newsletters is talking about everything from fusion to cell therapy to digitization. I mean, we are in a world where knowledge moves almost at the speed of light, or information does anyway, and systems can't keep up with it. That's why I tease about an innovation ecosystem. You know, what we once had was the doctor was the researcher. He had what knowledge he had. He met with my sister or my mother. He came to our house. He learned about our situation. He made his diagnosis and he treated us. That was the system. When he graduated, there was no great big profession behind him. But now we have a system, and it is extremely complex. In fact, the system almost has become the problem, because the systems by nature maintain the status quo. We need systems that are nimble and flexible and safe and affordable. God, that's almost a wrap up. I'm not in a wrap up. Go ahead.
I wanted to comment on a couple of things I heard, and one is a point on mortality, and the second is a point on China. And I think they actually are related points, because I really want to speak to this, the idea that, well, China is, you know, when China's going to move forward, and for sure China and the investments that happen in places like China, the United States, and elsewhere are not insignificant, and they do contribute to some new innovation and knowledge. But the fundamental thing I wanted to say here that ties in with what I think is more important, which is the point on values, and what problem are we trying to solve, and how does that impact not on just segments of society, but society as a whole. And I think this is every country has its problems to solve. And I think we as Canadians have to make sure that we're staying open to looking at how we're addressing this interest. And is the problem we're trying to solve really one of increasing mortality, like reducing, reducing mortality, I get, but I mean, to live forever. I mean, that is a problem to solve, I think is a ridiculous thing. So we can invest all of our assets into solving that, but frankly, not actually be addressing or expressing values that I think are more important. So I really thought that was important.
I'm going to give you, this is empirical. I'm going to give you some data to play with for a minute here. I have presented the following scenario to maybe 10,000 people in public speeches. When I talk about technology and managing change in the future, whether it's the future of healthcare or whatever, I play the following game. How many of you know of Ponce's Promise? Who Ponce de Leon was? Ponce de Leon was a French explorer seeking the fountain of youth. So Ponce's promise was one of, if I find it, we'll have everlasting life. So I asked the audience, how many of you would opt for everlasting life if you had the choice? What do you think the response? How many hands do you think I can count? I'll tell you, 8 hands maybe out of 10,000. Very, very few people raise the hand. So this issue of people thirsting for everlasting life, I've got data that says that's not what people are asking for. But then I pose the following. I tell them I'm confused. I've just offered you the promise of probably the most precious thing you've ever been granted, which is life itself, and you turn it down. How many of you would opt for another day? Everybody raises their hand. So then I said, now I'm really confused. You won't take an infinite amount of what is precious, but you'll take a day's worth. That seems to tell me something about what life is. How many years would you like? And they'd say about 100. Well, our biology seems to have solved the problem. There's something about life itself that's going on right now. And I think you're tickling it, David. I think every one of us in the healthcare system, or every one of us playing with technology, every one of us is aging, is into this little experiment that the world seems to be flirting with, of a health system that says, I don't know, that says there shall be no pain, or we will preserve your life forevermore. There's a value discussion underway or looming. And I think the medical profession has a role to play, but I don't think it's a medical issue. I think it's ultimately a political issue. And I don't think we're ready for that discussion, because those will speak up clearly. We'll do our very best to extend it as long as possible. I'm wondering if that really is the right message.
Randy mentioned the word values earlier.
Yeah, that's my point.
Individual choices and collective choices.
Well, and I'm sure that in the education of a doctor, these are the very discussions they have when they take their course in philosophy and values, that they're not just being given body health, they must be given values that relate to helping a person in the latter years understand what, it's just not the priest that will help them. They've got to help work that through as well. Because a doctor is about values. He values your life, your body, and yourself, presumably. Lawrence, you want to add anything more, or have I missed it? Christopher, any points you want to make? General public. We've got about 10 minutes yet. I see chat. Maybe I missed a question there. Yeah, we got that.
I wanted to say one other thing, and I spoke, the last time I spoke to the session, I put out a slide and it said this: by 2030, there could be a shortage of up to 100,000 physicians in the United States alone. And so when I think about innovation and I think about where we're kind of taught, what we're talking about today, and the opportunity of both precision medicine and personalized medicine and new technologies, I think that policy, frankly, generally leads the pathway on innovation. I can innovate all I want, but if I don't have policy pathways, forget about the care pathways that actually support innovating to solve problems like that one, which is just one problem of a bunch that we're facing in the next 10 years, then we're not paying attention. So I wanted to raise that point and recognize that there's some really serious problems in front of us in how people go through their lives. And I love the note I saw here earlier about to go through our lives with as little need to tap into medical services as possible. I thought was a good note. But I just wanted to put those things out there as why I think it's important, in my view, to innovate and to do that with people such as are here.
I'd like permission to speak.
Yeah, go ahead.
David, you mentioned that an AI doctor wouldn't replace the doctor, and you're absolutely right. But we do have Babylon Health out of the City of London, an investment that is now looking at the ability to provide enough information, in fact, more information than any one specific doctor would have on the state of the best practice in medicine, and then refer to a GP or a specialist. So I think in that regard, the personalization you're talking about, Perry, exists now. Our ability to use it, however, is stricter, and I think there's some other things that are impacting on that. And they probably have more to do with a meta physical than a physical construct. We talk about behavior and how it's a green space for science. Now, behavior is certainly not a green space. The metaphysical, religious, and other organizations of thought, practice, and morality have been in that game for way longer than science. So I think that when we look at the dangers that we're discussing here, I don't find as many. I'm rather contrarian, and I have way too many notes to talk to all of them, so let's focus on that. The concept of CRISPR and the commercial impetus. We talked of China and how they've helped. Also helped, but shit, didn't they also get arrested? So as I look at that, what I've seen in this conversation is an incredibly wonderful group of people who are much smarter than I am. I look at people like David when you talk about omics and DNA analysis. We also recognize, or at least I think, and this is a question to you, is epigenetics not a confounding factor in the development of those interpretations? And is not the challenge of the group culture or group structure defined? May I show you something? May I share a screen?
Dale, you posed a question. I'll let David
answer
that.
Certainly, please.
And then I want to call on John.
Okay.
Go ahead, David.
Yeah,
thank you.
Thanks for that. You brought up several really great things. I have to pick which one to respond to. So the epigenetics question, I actually thought about saying something about that earlier, because that's another fascinating opportunity, right? To leverage the scale of data that we can produce and use to help people. I mean, epigenetic modifications in a way they carry this legacy. You presented them as a confounding factor, which they are when it comes to sort of the vertical inheritance model of traits. But in a way, they're actually an opportunity, right? Because it's also, these are modifications that get embedded on our genome based on exposures and experiences and things that happened either to you or sometimes actually to your parents or even grandparents. I mean, the epigenetics can last for multiple generations. And so actually, yeah, that's a whole other area where there's an opportunity that we can, if we study people's epigenome, to actually know something about even what happened in their lifestyle or that of their parents, and that might impact their health too.
But wouldn't we also need to know, in context, to give it context, an environmental inventory or what the impacts on those behaviors were? Because sorry, just to put that in.
Hey,
yeah, oh yeah, no, that's absolutely true. And I'll just very, very quickly, because you mentioned the AI thing. Yes, I am also relatively bullish on the use of AI in medicine. I just don't see it as sometimes people almost have a vision of the AI doctor. I absolutely agree with you, though. The deployment of AI to aid in diagnostic and in prediction is potentially incredibly powerful. And I've been working on a few projects that look at doing this in a way that humans can't do. So it's really about sort of the responsible use, and that's where I see this really critical role sort of being sustained for doctors and humans in this process.
John, you have a comment or a question?
This was really quick. One, just quickly, I would have some cautions on some of the experience on Babylon and some of those kind of things in terms of the evaluations of how they've actually worked in the system and some harms that have been caused. Just following up on Chris's comment, just because of this whole thing for personalization, I think a lot of emerging evidence on what really impacts on health is much more around collectivism and community and influencing the day-to-day circumstances in which people live, not medical interventions per se. And I think addressing equity, dealing with equality and those kind of things are going to be increasingly more important. And that's where the health policy world is talking now more on that rather than sometimes new inventions and things. So I think we have to be careful about what things are going. The only other thing is, physicians is always the leader. My father was a clinician, a pulmonary physician, and he said, don't ask me to change people's behavior. I can diagnose lung disease, but don't ask me how to stop people smoking. Mm-hmm. There's other probably people who might bring the skill sets that are not physicians actually in trying to coordinate, and it's public policy and it's a bunch of other measures, which I think we're learning more about. So that was.
John, let's stay on that just for a minute. We've got a few more minutes. John, you want to comment on China's experience with this? I mean, it seems to me China is of the view that it can change behavior. It's got social data now. It's collecting enormous facial recognition. Well, our next webinar on the 30th of this month will be about the governing of data management. Health is just one domain of individual health or individual information that's being gathered. There's enormous behavioral data that's being gathered and collected politically in order to change and modify behavior. There are political systems with a lot of power that seems to have the capability of doing that. I think there was a book once written that had a date on it. Anybody remember what that book was? 1984, that's what it was. That talked about this.
China has a backdrop system for your cell phones. So they actually put a colored backdrop behind a person if you're doing business with them. Yeah. There's some international articles on this about 3 or 4 years ago. So they can actually profile the person in real time based on how they deal business with different people. And it shows up literally in the background of your phone.
Well, if you haven't read the book on surveillance capitalism, it talks about surveillance. I mean, you're doing surveillance, David, at a very molecular level. Randy, you're doing surveillance. We're educating people to do surveillance, called doctors and social workers and psychologists and politicians. And China seems to be way ahead of the game of wanting to gather that data in order to modify the behavior to ensure that they're compliant within the framework of a civil society, John. Maybe we need to catch up. Ling, you want to add anything there?
Sure. So first thing, I would like to caution, what precision medicine will do in ways we never even thought about. I don't want to mention which region and the country. There are, million or billionaires select, girlfriends or their daughter-in-law, son-in-law based on DNA tests. So are we going to do DNA tests for every student, employee, promotions, and select elite as a lead, and then keep the class? Those are social issues I think we never even thought about. Just like, we have the gun of freedoms, but gun kills people. We have technologies, but technology can be used for something else. So I think a lot of things we haven't really thought about this, right? And then other side, we talk about, technology used in China and something. And I'd love to have maybe another discussion with people who are interested. I live in 2 different countries. I can tell you perspective from both sides, right? How it's been used and the pro and the con. I see that. I see the both systems in my eyes. A lot of people I talk to, they see one side. They hear one side, but they don't see another side. I see both sides. I live in this country for 30 years. I live in China in 30 years. I've been backwards, go to China, and I talk to people there all the time. So I can tell you, and what's good, what's bad, why people doing this, and where they're going, and what things need to be cautioned about. So I think I'm also in business related to that. We try to create a job for people who can help themselves, or they don't have any opportunity before. So now are we going to use the tool to select who we're going to help with? Obviously, that's not going to be very helpful for the society. So I think everybody needs to be keeping in mind for that.
Ling, you have convinced me earlier to put a webinar together about China, what's to be learned or what's to be feared. And that will occur later on this fall. And you and I will talk about a panel, not specific to healthcare, but it will clearly emerge because of the data that's being gathered in all systems, that is being gathered by the state and being used to the interest of, quote, the public. If the person's behavior is not aligned with the interests of the public wins. You're seeing in North America, which is always heralded liberty and freedom and individual civil rights as sort of a central point of it, how it differs from the rest of the world. And is finding it problematic right now in the face of COVID. Your comments, John, we're in the middle of it right now as associated with how to modify individual behavior in the face of something that is believed to be putting the public at risk. The politicians are right smack in the middle of it today.
Thanks, David. Bye-bye. Thanks, everyone.